School-Based Health Alliance would like to welcome you to the class of 2016 to the Leadership Fellows Program. We are excited to share in this journey with you to increase your knowledge of school-based healthcare and to enhance your leadership skills to continue the important work of this movement. As you are aware, the School-Based Health Alliance is the national training, technical assistance, and advocacy organization for the field of school-based healthcare, and we, the national office, are only as great as those that we serve. Our vision is to see all children and adolescents healthy and thriving, and we accomplish this vision by improving the health status of children by advancing the work of school-based healthcare. You will learn lots more about the School-Based Health Alliance, but let me introduce you to our leader who will walk you through a bit of a history lesson. John Schlitt is the president of the School-Based Health Alliance, and from 1997 to 2008, John served as School-Based Health Alliance's first executive director and led the organization's advocacy, education, and technical assistance efforts. In 2011, he rejoined School-Based Health Alliance after exploring other public health interests. John's 25-year career spans maternal, infant, and child health policy practice and advocacy arenas. He is a national authority on school-based healthcare financing, organization, and delivery. He has worked as a clinical social worker with adolescents in psychiatric and community mental health settings and has authored several articles on school-based healthcare and teen pregnancy prevention. His extensive knowledge and experience and passion for this work equips him to share a brief historical background of the field.
Thank you, Letitia, and hello, Leadership Fellows. John here. I am pleased to provide for your wonder and amazement the history of school-based health centers in one slide. I first want to preface that my brief presentation here is a generalization, of course, and then not every school-based health center fits the patterns that I'm going to share. But I describe the growth and evolution of school-based health centers into three periods of time, or three generations, if you will, spanning 50 years. The first generation of school-based health centers was during the 1970s through the 1980s. School-based healthcare 2.0 was during the 1990s and 2000s. School-based healthcare 3.0 is beginning about the same time as the Affordable Care Act, and I'll say a little bit more about each of these periods of time. So let's start with the 1970s and 80s, school-based healthcare 1.0. The model I'm calling here is sex clinics. Now, this is clearly a pejorative term, but it was earned by primary focus on teen pregnancy prevention and birth control access and STD treatments. The early school-based health centers in the 70s and 80s were very much focused on the need of adolescents to have meaningful access to reproductive health care and birth control and STD prevention services. That was a very important and primary focus of the school-based health centers, which in fact earned its pejorative term, sex clinics. The targets were primarily inner-city minority females, again, who had very limited access to health care in their communities. The leaders of the school-based healthcare movement at this time thought, why not move our clinical services into places where these young people are every day, where they are learning and growing, their schools. So this gave way to the birth of the first, what we called school clinics at the time, but as you will hear, soon transformed into a new name. With regard to systems of care and school-based health centers, bottom line was in 1.0 there weren't any. And that's primarily because low-income adolescents at this time were still largely uninsured. There was no one to bill even if you wanted to. There were no provider systems to link up to even if you wanted to. And so there was no connectivity across other programs for the most part. The school-based health centers were highly fragmented from other providers of care, and there was very limited accountability for what the clinics were doing. Not to say that they were not providing high-quality care, but nobody was really asking for any kind of data back to demonstrate the kind of quality and outcomes that they were delivering. And speaking of data, at this point in time, the data was largely unsophisticated, with a few exceptions, but the emphasis on data in our field was on the storytelling and on the annual reports to the funders. So it was very much limited to anecdotes and stories about the effects of school-based health centers, less on the empirical evidence from the field. I mentioned there were a few exceptions, and there were a number of providers and school-based healthcare researchers who were involved in some of these programs that were attached to academic centers, who were very much involved in collecting data to demonstrate the impact of these services. As for funding, most of the dollars going into these programs are coming out of national and private sources. Public payers weren't really engaged on any significant scale in the 1.0 era. Shifting now to 2.0, the 90s and the 2000s, here our focus shifts, or broadens rather, in recognition of the increasingly poor access that low-income children and adolescents had to primary care. We're now shifting from sex clinics to doc in the box, where we're functioning as an expansion or a satellite of community-based primary care programs. Our focus is on acute care and chronic management and attending to the behavioral health issues of children and adolescents who are attending schools that have school-based health centers. Teen pregnancy prevention STD efforts don't go away by any means, but the field becomes acutely aware of the fact that children and adolescents have other needs besides reproductive health, and increasing numbers of programs are opening up school-based health centers, especially in elementary schools now, because they recognize the gap in primary care access for young children. The target now broadens away from inner-city minority females, or I should say inclusive of inner-city minority females, to all at-risk children, not just urban adolescents. We're now thinking of at-risk children in rural communities and suburban communities as well in the 1990s and the 2000s. As for systems, well, there is a huge transformational period for school-based health centers in the 90s and the 2000s. We are now focusing on the business of the model. It gets a lot more attention, and with good reason, because more adolescents are becoming covered by Medicaid. So the business case for billing patient revenue becomes increasingly more important, and it replaces private philanthropy, in fact, as the critical linchpin in the sustainability of school-based health centers. So in 1.0, we weren't connected to anybody or anything. In 2.0, we're starting to understand the importance of a good business practice, of understanding who's insured and who's not insured, of optimizing patient revenue, of becoming connected to larger systems of care like managed care organizations and HMOs. With regard to data, we're figuring out now what needs to get counted and how do we evaluate our impact on access, and yes, how do we make a stronger connection to school performance. So we're really shifting the way we talk about our effects, not just through anecdote and through stories, but now through real data. And in part, this is driven by the systems connection and the need to be collecting data for payers. Funding also shifts quite dramatically in 2.0. This is a period where the states are really showing up in a big way. They are, in fact, one of the largest contributors to the growth of our field. Not only are state governments, like state public health departments, departments of education, providing grant funds for school-based health centers, but they're also providing technical assistance around and facilitating Medicaid payment to school-based health centers, creating policies that help school-based health centers maximize Medicaid. This is also a period of time in which the federal government creates its first ever program called Healthy Schools, Healthy Communities, which was essentially an appropriation under the 330 safety net programs that for about 8 to 10 years was directly funding school-based health centers out of the federal government. Now that program would merge with the larger consolidation of community health center efforts and would go away. We would not see a resurgence in federal funding until after the Affordable Care Act. Shifting now to school-based health centers 3.0. As I mentioned, this evolution was really brought about by the passage of the Affordable Care Act in 2010, which for the first time is asking of our health system to create a system of care focused on wellness and not just sick care. So as we think about a 3.0 system, a system of wellness and prevention, this is really a generation that is in progress. This is an aspiration, a focus where we are moving upstream of the disease process to get to the root cause of disease. I don't think we as a field are at 3.0. Maybe we're at 2.2 or 2.5, but we are getting there. We must get there. Our target now becomes not just at-risk children, not just the students who walk through the school-based health center door, but we have to begin to think about the population of all the children in the schools that we serve. Who are the kids and students and teens who aren't coming into the school-based center who might have health needs? For the first time, we're really compelled to think about that population as we try and shift the cost curve, bend it so that we are providing more preventive services that are going to have a more long-term yield or return on investment in our healthcare system. Our systems are now all about integration, all about becoming part of a larger system of care, becoming linked to accountable care systems through global budgets, exchanging data with a larger provider system, taking on the responsibility of the patient-centered medical home and care coordination. That's where the value added to school-based health centers is in the larger systems of care. We can no longer afford to be lone rangers. We have to be connected to these larger systems. Every public health grant source is going to be scrutinized over the next decade to see where can we squeeze out the most money to be putting into our prevention systems of care. So carve-outs are out and carve-ins are very much in right now. In respective of that with regard to data, it's really about quality now and not quantity. It's about demonstrating our value, our cost savings to the system. We have to develop more sophisticated data systems to be able to tell that story about how we are delivering a quality of care that is at the standard that is expected of all providers in our systems. And I have every expectation that school-based health centers will not only meet that standard, but exceed it when given the opportunity. And finally, with regard to funding, we will continue to rely on foundation and philanthropic and community trust funds. We will continue to need state and federal government dollars. We most assuredly will continue to need Medicaid, but increasingly we will also be looking to health plans and health systems to round out the resources that will enable us to generate patient revenue, but also be able to have the kinds of resources we need to continue to do the kinds of services that most standard payers simply aren't going to be paying for, like health education and population level care. So I hope you've enjoyed this brief presentation of school-based healthcare history 1.0, 2.0, 3.0. I would just like to close by showing you a graph of the growth of school-based health centers from 1987 through the present. The graph enables us through the census process to track the growth of the field over time, and as you can see, it has been a steep incline. We're very pleased with the continued growth as represented by the red line. It's on a very nice pitch there, and you can see that across the country through the red dots, the proliferation of the school-based health centers has reached nearly every corner geographically of the U.S. If I may, briefly, the colors of the states reflect where the School-Based Health Alliance has active or emerging state affiliates. Those are indicated by the blue, dark and light blue colors. And the brown states represent either non-affiliated associations or non-affiliate states. Clearly, we expect over the next 3 years for those number of red dots to grow. Our goal is 30% by 2018, and I expect with your help that we are going to achieve that goal and then some. So again, thank you for giving us your time today for this brief presentation on the history of school-based health centers. I'm going to turn it back over to Letitia, who's going to wrap it up.
Thank you so much, John. Again, that concludes our brief history lesson for you today. Should you have any questions about this presentation or school-based healthcare in general, please feel free to contact myself, Letitia Winston, via telephone or via email. For more history and some insight from pioneers in the field, we are going to include a few leadership interviews for your listening pleasure. And we look forward to a rewarding learning experience over the next 9 months and congratulate you on taking the first steps to a fulfilling career in school-based healthcare. Thank you so much.